Hello again. Finishing up the medication review. Next week we'll be going into schizophrenia and psychotic disorders, and as such, we're going to be recovering antipsychotics. Antipsychotic medications are tricky because there's a whole lot of things going on. So we have two types of antipsychotic medications. Conventional, got your I can't say all of these, y'all. Who am I kidding? This is Thorazine, this C1, and this is Haldol. You really don't see very much of these anymore, right? Atypical antipsychotics are what we see a lot of: Abilify, clozapine or Clozaril, Zyprexa, I don't know what paliperidone is called, Quetiapine is Seroquel, Risperidone is Risperdal, and Ziprasidone is Geodon. So atypical are your second generation, and conventional are your first generation, or also known as typical. Why they have so many names, I don't know. So your first generation, typical, conventional antipsychotics, whichever you want to call them, they're used to treat schizophrenia, bipolar disorder, and some personality disorders like schizotypal. They affect dopamine. Dopamine causes hallucinations, right? So these are going to help more with positive symptoms. You'll understand more about that later, such as hallucinations and delusions. Why? Because dopamine causes hallucinations. However, it has lots of side effects. Extrapyramidal symptoms, EPS, agranulocytosis, which we're going to talk about, and anticholinergic symptoms. Y'all should hopefully be familiar with anticholinergic symptoms by now. Patient education with these, we always need to be open and honest and talk about the side effects. There are so many. We need to refer to a psychiatrist or provider if they need more education. And we must have informed consent in most facilities before giving the patient these medications. This is straight out of your book, Table 7.7, Extrapyramidal Side Effects of Antipsychotics. Extrapyramidal side effects is a fancy way to say movement. We're going to go more in depth on these in the next few slides. Because of the dopamine that those first generation antipsychotics are affecting, that's why you're going to see more of these movement disorders, including that pseudo-Parkinsonism, drug-induced Parkinson. Parkinson involves dopamine. Hallucinations involve dopamine. Our meds fix dopamine. We start messing with dopamine and we call this Parkinson's. So extrapyramidal side effects. Akathisia. Akathisia is the inability to sit still. There's an inner restlessness, and it almost appears as if your client is in more anxiety. Hey, my client was anxious. I gave him some Haldol, and now they're pacing, like their feet, especially you see this in the feet, are just continuously moving. They physically can't stop it. That is akathisia. What do? We let the client pace. Just let them walk. Give them a hallway and let them walk back and forth. No matter what you do, how much you let them pace, it's not going to fix it. They just need to ride this out. Akinesia. A is a prefix which means without, and kine means movement. So akinesia means without movement. So this is a side effect where there's just an absence of physical or mental movement. There's delayed responses or freezing, and the patient just doesn't move. This is an extrapyramidal side effect we need to be aware of. Now, you can see Parkinsonism. It's called drug-induced Parkinsonism or pseudo-Parkinsonism. And that is made up of a few different kind of more typical that you see. This is that Thorazine shuffle, right? Stooped posture and rigidity, shuffling gait and tremors, pill rolling of the hands. It looks like if you were to put a pill in between their fingers, they just sit there and roll them back and forth. But then also you see bradykinesia, right? Brady means slow. That kind is still there, and that's movement. So a slowing of movement. Dystonia, I wish y'all could see my face for this, right? Dystonia is that muscle spasms, facial grimacing. You see all the muscles in their face, their neck, their back start to tighten. Involuntary eye movement, the oculogyric, I don't even think I'm saying that right. I can't say these words, y'all. Crisis, their eyes just start to look at the ceiling, and their eyes are just fixed at the ceiling and they cannot move it. This is honestly a medical emergency if they get it because of the possibility of laryngeal spasms. We have to treat ASAP due to breathing concerns, and usually treatment's Benadryl. Maybe some Cogentin, which Cogentin is a Parkinson's med. Neuroleptic malignant syndrome is a medical emergency. This is a patient who all of a sudden presents with a super high fever, suddenly without any cause. They're rigid and has an altered mental status. Right? If your patient wakes up in the morning and presents for MedPass or you go find them because they're not coming from MedPass and they look like this, you call the doctor right away. You don't give medications. The best thing we can do is treat the fever. There's really no treatment for this. So we have to be aware of a sudden high fever without any other cause, rigidity, and altered mental status, and that is neuroleptic malignant syndrome. Tardive dyskinesia is the worst because it's irreversible. This is a lot of weird involuntary mouth movements. The tongue's sticking out, they're sucking and smacking at their lips. It almost looks like they're continuously maybe like chewing on gum or the side of their mouth. And there's involuntary repetitive movement of the body. We need to stop the medications, or we need to just hope for the best, because these are not going to go away. And it's really hard sometimes with these patients. Do you stop the medication or you keep them on it? Second generation atypical antipsychotics. So same thing, right? Same uses, schizophrenia and bipolar personality disorders such as schizotypal. They affect dopamine, and I missed this on here, they also can affect serotonin. They help with more of the negative symptoms, so withdrawing from society that we see in schizophrenia because of that serotonin. The dopamine is going to help a little bit with the psychosis, and the serotonin is going to help with the depression and withdrawing from society. But they have lots of side effects: metabolic syndrome, extrapyramidal symptoms, and anticholinergic. Patient education is the same. We need to make sure they're aware of what is going on with these medications and what the side effects are. Second generation atypical antipsychotics, increased risk for metabolic syndrome. So what does that mean? We're looking out for weight gain, increased lipids, increased blood sugar, diabetes, and hypertension. There's less of a chance of all of those extrapyramidal symptoms, but it's still possible. So we need to talk to our patients, especially those who are out of it, which is hard, to watch for weight gain, right? We need to assess, why did you stop taking your medications? Not taking medications because of weight gain is a big one. What do you do if a patient is finally stable on their Zyprexa and all of a sudden now their A1C is high? Sometimes we do education and we throw metformin at them and hope it works. So these are super complicated, especially in American society, and we need to watch out for those metabolic symptoms with those second generation atypical antipsychotics. Agranulocytosis. Oh my gosh, y'all. This is one y'all need to know, right? So back to our terminology, A is without, and granulocytes. Granulocytes are a type of white blood cell. This is a possible side effect with all antipsychotics. However, it's seen so much more with clozaril, also known as clozapine, that there's a black box warning on clozaril. So those granulocytes are a type of white blood cell. Low white blood cell count is neutropenia. If a patient's neutropenic, they have no ability to fight infection, and it can lead to death. Nursing interventions. Cautious when administering medications with a sudden fever and signs and symptoms of being sick. So just like with neuroleptic malignant syndrome, it doesn't necessarily have to be a high fever. In this instance, though, your patient could wake up one day and they've been on clozaril and all of a sudden they're complaining of like a little bit of a sore throat and a headache, and they're at like 100.2. We'd still want to assess that patient, even if it is 100.2, right? That's not a fever by textbook definition, but we would need to get a CBC immediately. These patients need special doctors and even special pharmacies because of the frequent lab draws. Pharmacies cannot dispense the medications if labs have not been drawn. Patient teaching is extra important because of signs and symptoms of possible infection. This is super important one to know, more so because of that clozaril and that black box warning and the risk of death. Bonus slide, in case y'all didn't see this. So anticholinergic reaction, right? We see dry mouth, decreased tearing, blurred vision, constipation, urinary hesitancy or retention, and excessive sweating. Can't see, can't pee, can't poop, can't spit. Hypertensive crisis, right? Throbbing, radiating headaches, the stiff neck, the palpitations, tightness in the chest, sweating, high blood pressure and pulse. CNS depression is also seen in the antipsychotics. Changes in level of consciousness, sedation. We use these medications sometimes just because they're sedating. Increased lethargy, disorientation, confusion, agitation, hallucinations, and a lower seizure threshold. So we need to watch out for these side effects too in these antipsychotics, and honestly, most of our medications. If y'all have any questions on these, reach out and let me know. Otherwise, have fun studying.